Good morning, everybody. My name is Teresa Chapa, and I've had the privilege to serve as the chairperson for today's event. On behalf of Fred Finch and Family Services, Youth and Family Services, I should know my own name, and our partner, the California Alliance of Child and Family Services, I would like to welcome you to today's summit, Bridging the California Mental Health Workforce Racial Equity Gap, a Call to Action. It was about a year ago when a small group of us got together to discuss our concerns about the diminishing mental health workforce. More specifically, the critical need for a more racially, culturally, and linguistically diverse mental health workforce, one that could meet the ever-increasing demand for services in our state. After all, California is known to be the leader in almost everything. In fact, we're considered one of the most innovative and diverse states in the nation. For example, we have the largest Latinx population, the largest percentage of Native Americans. We have close to 11 million foreign-born residents, a sizable Black population, and a fast-growing Asian population. We are also the most linguistically diverse state in the country, with more than 200 languages spoken. Yet, despite our numbers and multiple strengths, our diverse communities continue to be highly underrepresented across all mental health disciplines, with critical intersections not being addressed. Our small group, now a steering committee, wondered why, after decades of federal, state, and philanthropic research, papers, recommendations, and investments, that our representation in the field remained significantly low. So we decided to take a different approach and to look at our current situation as an opportunity to find and share solutions, approaches that are both standard and atypical, and convert them into actionable and impactful next steps. We decided to seize the moment and change the conversation. Although some considered our objectives too bold and too big, community members felt inspired, hopeful, and heard. Today, you're going to hear from our distinguished speakers, subject matter experts, thought leaders, stakeholders, and influencers, and hopefully become inspired to join our movement. Please take the time to read about today's participants as they represent the best in our state, various age groups, populations, communities, as well as their intersections. To learn more about them, hover over their picture or their names on the agenda, and their bios will pop up. Our day begins with a tribal blessing by Miss Lisa Elgin of the Manchester Point Arena Band of Pomo Indians, followed with words of welcome by our summit partner leadership, Mr. Tom Alexander and Ms. Chris Donor-Mertz. Many thanks to both of you for your enduring support with this long process. Additionally, we are deeply honored to have support and a call to action from congressional members Judy Chu and Grace Napolitano, as well as a keynote from Elizabeth Landsberg, Director at the Department of Healthcare Access and Information, a change of name from Oshpit, and then a final welcome with Joe Patterson from National University, our lead summit sponsor. We ask that you stay tuned for our 2 youth panels, followed by our expert breakout sessions. We promise that you will be inspired. Finally, many thanks to our steering committee members who worked tirelessly to make this event possible. Let me just name our members, please. Adrian Shilton from the Alliance, Julie Henderson, Fred Finch, Carly-Ann Rubsik, Fred Finch, Vanessa Calderon, Fred Gonzalez Hunter, Fred Finch, Robin Levinson, West Coast Children's Clinic, Eva Terrazas, Uplift Family Services, Susanna Marshland, Fred Finch, Cornell Jenkins, Catalyst Center of the Alliance, and Max Gade, Alliance. And one last thing, when sharing on social media, make sure that you use our hashtags. Max, you're going to put them in the chat so that people can use them. And now I'll move on to our next speaker.
Good morning. My name is Wendy Wang from Sycamores, a member of the steering committee. In California, we are fortunate to have several members of the congressional delegation who understand the importance of addressing mental health disparities and strengthening the mental health workforce to deliver culturally responsive and linguistically appropriate care. One of these members is Judy Chu, who represents the 27th Congressional District. Throughout her distinguished career, Congresswoman Chu has championed the needs of the Asian American and Pacific Islander communities. Please join me in watching her pre-recorded remarks for today's summit.
Hello, I'm Congressmember Judy Chu, and I'm so happy for the opportunity to join with Fred Finch Youth and Family Services, the California Alliance of Child and Family Services, and all of you here for today's virtual summit on how we can improve mental health in this country by improving racial equity in the mental health workforce. Mental health is not always easy to talk about, especially in the Asian American and Pacific Islander community. But that can change with the right professionals having the right conversations. That is why I'm so grateful for the work you are doing to increase culturally competent care so that every community can receive the mental health care that best suits them. This is especially important after the past year and a half, where so many are struggling with feelings of isolation, sickness, and grief, along with increased racial violence and discrimination. From an historic reckoning with our country's own history of racism, to increasing anti-immigrant rhetoric, to the spike in anti-Asian hate crimes, the need for mental health services is rising in communities where mental health care is also harder to come by. This is particularly true in AAPI communities where xenophobia and bigotry have led to over 9,000 anti-Asian hate incidents since last March alone, leaving many across the country to worry, will I be next? That can take an incredible toll on an individual and on whole communities. That is why right at the start of the pandemic, the Congressional Asian Pacific American Caucus, or CAPAC, which I am the chair of, worked with researchers to collect and compile data on the impact of the pandemic on the AAPI community. We specifically asked that they include mental health in that assessment because we knew how important mental health was to the story of AAPIs in the pandemic. This spring, they finished tabulating and analyzing the results of that survey, and they found that 3 in 10 Asian American adults faced discrimination during the pandemic, and that 75% of Asian Americans believed that the United States had become more dangerous for Asian Americans over the course of the year. They also found that out of everything in the past year, the greatest stressor on the Asian American community during the pandemic was, indeed, mental health. Even before the pandemic, AAPI mental health was hurt by a number of barriers like language, culture, and geography that often kept AAPIs away from the care they need. It is clear that we must do more to address the mental health needs of the AAPI community right now because we know these attacks on Asian Americans have led to increased stigmatization and racial trauma in our communities. And yet, AAPIs are less likely than other racial groups to seek mental health services, which is a problem that is often exacerbated due to systemic barriers to accessing culturally and linguistically competent care. That is why this May I introduced a resolution designating May 10th as National Asian American, Native Hawaiian, and Pacific Islander Mental Health Day to raise awareness of the importance of mental health for the AAPI community. I am also one of 2 psychologists in Congress. So I know firsthand the problem of stigma in the AAPI community and how that prevents many AAPIs from seeking or receiving the treatment they so desperately need, either for themselves or for loved ones. So that is why this year I also reintroduced my bill, H.R. 3573, the Stop Mental Health Stigma in Our Communities Act, which would create a grant program at the Substance Abuse and Mental Health Services Administration, or SAMHSA, specifically for outreach and access to mental health resources for the AAPI community. This program will connect AAPIs, including those who are direct victims of hate crimes, to culturally and linguistically appropriate mental health services from trusted providers who are already working in our communities. From standing up against hate to encouraging members of our community to treat their mental health as seriously as they treat their physical health. There is so much that we can do to address the inequities in our mental health system that AAPIs face. That is why I'm so glad that you're having this critical discussion today. Thank you for including me in today's summit, and thank you for all that you are doing to address racial and ethnic disparities in mental health.
Another member of Congress who has been a tremendous leader in elevating the issue of mental health and fighting for mental health parity at the national level is Congresswoman Grace Napolitano. As founder and co-chair of the Congressional Mental Health Caucus, Congresswoman Napolitano has tirelessly fought for greater federal resources and investment for mental health care and support for all students. Please turn your attention to the screen to hear her pre-recorded remarks. Thank you.
Hello, I am Congresswoman Grace Napolitano, and I proudly represent California's 32nd District. Thank you to Fred Finch Youth and Family Services and California Alliance of Child and Family Services for putting on today's briefing and for inviting me to participate. I co-chair the Congressional Mental Health Caucus with my very good friend John Katko of New York. We are 101 members strong and growing, and the caucus works to educate members, staff, on this very critically important topic and welcomes input from mental health providers. We have come a long way in making mental health a priority in Congress, but mental health still remains underfunded and misunderstood and still affects millions. It is vital that we educate all our communities on this very important issue and reduce stigma, especially our communities of color. COVID-19 has only made it worse, the ongoing mental health crisis in these communities of color. We must continue to increase culturally and linguistically appropriate services at all levels and continue to work the much needed mental health workforce. These are a few ways I am working to address the issue. If we address stigma with services early, when they're young, we can help students and their families of color succeed. It is critical that we provide schools the resources to create a mental health plan in schools to help their students during this stressful time. I know this firsthand from my decades of direct local involvement. In 2001, after learning that 1 in 3 Latina adolescents had contemplated suicide, I secured $500,000 in federal funding from SAMHSA for a pilot project. We partnered with Pacific Clinics in Los Angeles County and started the now successful Youth Suicide Prevention Program. The schools were very resistant at first because of the ever-present stigma, but the program has grown to 35 schools. It serves as a model for the H.R. 721, the Mental Health Services for Students Act, which would provide funding for school-based programs nationwide. H.R. 731 passed the House in May, and we hope it soon comes to the Senate floor, maybe. Machismo and other cultural tendencies still prevent our loved ones from being open, honest about what troubles them. I have introduced H.R. 2529, the Mental Health for Latinos Act, to address this particular issue. It directs SAMHSA to develop and implement an outreach and education strategy to promote mental health in our Latino community. Also would further identify gaps in access during this pandemic, reduce stigma, and include the participation of both consumer and community members in the development and implementation of materials. This reinforces the message that there is absolutely zero shame in asking for help. To address the mental health workforce shortage, Representative Katko and I have introduced HR 3150, the Mental Health Professionals Workforce Shortage Loan Repayment Act. The bill would authorize a loan repayment act for mental health professionals, those who work for a period of time in the federally designated mental health professional shortage area. The Health Resources and Services Administration reports over 107 million Americans live in a federally designated mental health professional shortage area, and in our Latino community, only 1 in 20 individuals receive service from a mental health specialist. So in July 2022, the National Suicide Prevention Lifeline will be available and switch to a 3-digit number, 988. Again, 3-digit number to be 988. Representatives Kako, Representative Bayer, and I have introduced HR 2981, the Suicide Prevention Lifeline Improvement Act. It would increase funding for the Lifeline and ensure the delivery of high-quality service. The bill would also provide a report on services to foreign language speakers because we want to ensure all can call in for help. Our work continues, but it cannot and must not be limited to Congress. I encourage all of you, everybody, get involved. Continue to educate all your elected local, state, federal, on this very important topic, and share knowledge, your knowledge, with friends and family. Because if you see someone who has fallen on hard times, talk to them, help them out, and refer them to a mental health service provider. Together we can strengthen the mental well-being of all the communities and eventually live in a world where there is no stigma. Thank you again, and stay safe, and God bless everybody.
Good morning and welcome to Bridging the California Mental Health Workforce Racial and Equity Gap Summit. My name is Tom Alexander and I am the CEO of Fred Finch Youth and Family Services. First, I want to extend our sincere appreciation to our sponsors who made this summit a reality. Many thanks to John Muir Health, Kaiser Permanente, the Hispanic Latino Mental Health Technology and Transfer Center, Proco Risk Management Services. Thank you for your generous support. And finally, thanks to our lead sponsor, National University, for their leadership in both innovating education and supporting the important work of this summit. As one of the partners that made the decision to undertake this summit, Fred Finch is committed to facilitating deep and honest conversation and dialogue to pave the way for innovative approaches and actions to address racial and cultural gaps within our system of care, so that we may improve our services and generate more positive experiences for those that we serve. Fred Finch is proud to take a leadership in partnership with the Alliance, the California Alliance, on such a vital topic, and we are pleased that of the enthusiastic response from our summit participants. Only together will we have real and lasting impact on the system-wide issue. From an organization dedicated to providing the highest quality behavioral health services that is truly culturally responsive, I believe we have 3 overarching tasks. From an organization dedicated to, first, we must build, implement, and create strategies to increase the capacity of our workforce pipelines and to build new and different pathways to behavioral health careers, recognizing that the diverse workforce will come from the communities we serve and that we must create interest and opportunities for career growth and advancement. In some ways, the diverse workforce shortage is as simple as a numbers game. We need more folks interested in behavioral health and recognizing a path for themselves for engaging, satisfying work experiences. Second, We must, as a community of providers, develop training programs that prepare the workforce for culturally and linguistically sophisticated and responsive service. Not only will we improve the quality of our service, but we will also begin to break down barriers to access and engagement, address issues surrounding stigma, recognizing that our workforce are able to provide service and assistance in a way that celebrates and embraces our differences. Third, and most important, we as employers must begin the tough work of becoming anti-racist organizations, dedicated to eliminating racial inequities and institutional bias. As we are successful in building that pipeline and preparing and training our employees, we can also retain them in a rich and culturally diverse environment that recognizes and celebrates our differences while intentionally sorting through the vestiges of racism and dominant culture influence. It is in this third area where we at Fred Finch are most proud of our progress. From our educational equity programs designed to provide improved access to educational and training opportunities, to our work on addressing microaggressions in the workplace, to our implementation of our strategic racial equity plan, Fred Finch is creating a more racially aware, just, and equitable organization. For without these efforts, our success in the first two initiatives is lost. Our opportunity today is about discovery and collaboration, sharing fresh ideas, solutions, and taking our next steps towards closing the mental health workforce gap. We are so lucky to have with us today a multidisciplinary team of key experts, thought leaders, influencers, and stakeholders who will provide us the framework to begin our sharing of new innovations, concepts, and initiatives to lead us to a more diverse and culturally responsive system of care. Last, I challenge all the participants in today's summit to be creative, to embrace our diversity, and to commit to putting the work of the summit participants into action. A challenge of this magnitude demands our active collaboration, partnership, and collective innovation. Again, thank you for participation today, and let's generate some solutions. Thank you.
I want to just thank Tom and the Fred Finch staff for their leadership in focusing our attention on the significant need to address the gaps in our mental health workforce, and in particular, the need to create a much more diverse community of service providers that can meet the needs of those in the public behavioral health system. I'm the CEO of the California Alliance of Child and Family Services, and we represent over 150 nonprofit community-based organizations, most of whom are doing mental health and substance use services in their communities. As a broader California community of policymakers, service providers, and public servants, we must take seriously the need to dismantle the institutional barriers that have resulted in the stigma and lack of access to culturally and linguistically appropriate services. It starts with whether a person feels comfortable with the professional they are engaging with. And until our behavioral health workforce fully reflects the people in the community it serves, we have not met our goal. We are grateful to be partnering with you and so many others today, and look forward to listening and ultimately acting on some of the ideas and solutions that are being proposed today by young people and others that are committed to creating our future behavioral health workforce. We have remarks from Senator Alex Padilla and Representatives Grace Napolitano and Judy Chu, all of whom are champions for a strong behavioral health system. They've authored legislation to address stigma, access to services, and funding for school-based mental health. I look forward to hearing from them and working with them and our state policy leaders to make real change that improves our ability to meet the needs of all that deserve culturally responsive behavioral health services. Thank you.
Good morning. I am so pleased to introduce Elizabeth Landsberg as our keynote speaker today. Director Landsberg was appointed to lead the Department of Healthcare Access and Information, HCI, by Governor Gavin Newsom in December of 2020. HCI is formally the Office of Statewide Health Planning and Development. Previously, she was Deputy Director at the Department of Managed Healthcare, overseeing the HELP Center, which assists consumers and providers with healthcare complaints. Before joining DMHC, Elizabeth was an advocate for healthcare consumers in the nonprofit realm for over 16 years. She was a director of policy and advocacy at the Western Center of Law and Poverty, where she specialized in healthcare access issues, healthcare reform, implementation, Medi-Cal, Covered California, and more. She brings a wealth of experience and knowledge about behavioral health care, and with so many important workforce initiatives that will be overseen by HCI, the California Alliance is thrilled that Director Landsberg has taken the helm of HCI, and we are so honored that she is keynoting our Workforce Summit today to talk about these initiatives, and particularly as they relate to the workforce serving children, youth, and families. Director Landsberg, welcome.
Good morning. I'm Elizabeth Landsberg, the Director of HCI, the California Department of Healthcare Access and Information. We're the department formerly known as OSHPD, and we just graduated from an office to a department. I'm thrilled to be here this morning talking to you, and want to extend my thanks to the California Alliance for inviting me to speak this morning, and for each of you for the work that you do supporting children, youth, and families. It's an honor to share the virtual stage with so many impassioned leaders for improving mental health services for all Californians. As you're on the front lines every day, you're seeing firsthand that we had acute behavioral health needs before the pandemic, and those have just been exacerbated by COVID-19, by the economic strain that many have experienced, as well as by the bias and violence against communities of color and many other vulnerable communities. So I'm really pleased to be here today to talk about what we hope to do to address some of those issues, and specifically HCI's efforts to increase the racial and linguistic diversity of California's behavioral health workforce. I wish that we could be in person so I could both have more give and take and connect with you, but I'm hoping to be able to listen to some of the panels later today, and I'm so pleased that there are some panels where we can hear directly from youth about your needs. HCI has a broad range of healthcare workforce programs designed to increase the number and diversity of people entering the health professions. Our programs specifically focus on primary care, behavioral health care, and oral care positions from community healthcare workers to doctors and psychiatrists. We have programs ranging from pipeline programs to attract and support more people in entering the health professions, all the way to funding residency slots to help train doctors and psychiatrists in hospitals and clinics. HCI runs loan repayment and scholarship programs for providers serving in underserved areas. With all of our workforce programs, we have core goals. One of them is to increase the workforce serving the medically underserved areas in California. We have wonderful data folks who are really looking at each of your regions and identifying those medically underserved areas, and we're focusing our workforce initiatives in those areas. All of our programs seek to increase the racial and linguistic diversity of the workforce that we're supporting, and then to increase the provider serving Medi-Cal members. We know 14 million members of California are on Medi-Cal, and we're very committed to growing the Medi-Cal workforce. So those are some of the broad parameters around our workforce programs, but I'm really excited today to talk specifically about the Children and Youth Behavioral Health Initiative. California is embarking on an initiative to truly transform our child and youth behavioral health system into a world-class, innovative, upstream-focused ecosystem where all children and youth, from literally birth to age 25, regardless of payer, are routinely screened, supported, and served for emerging and existing behavioral health needs. So we don't care whether kids have Medi-Cal or commercial coverage or both or go back and forth. Wherever kids are at, we want to be reaching them and have the workforce to reach them to assess their needs and to provide the behavioral health supports that they need. The Children and Youth Behavioral Health Initiative aims to provide services that are statewide, evidence-based, culturally competent, and equity-focused. So why are we doing this and why are we doing it now? We know first and foremost that serving young people and doing it well pays off. Half of diagnosed mental illnesses begin by the age of 14 and 3/4 by the age of 25. So investing in our youth pays off. It's good prevention. The adolescent substance use disorder system in California is under-resourced and under-scaled, so we know that the need to improve that system has never been greater. And then of course, as you all know and see every day, COVID-19 pandemic has intensified children's behavioral health issues. Addressing these needs is vital to California's recovery. How can we recover as a state if we don't provide the support our youth need? The state's children's behavioral health system is not up to the task to meet the growing demand for services. There is too little focus on prevention today and too few behavioral health professionals and services at every level. The most glaring behavioral health challenges are borne inequitably by communities of color, low-income communities, LGBTQ+ communities, and in places where adverse childhood experiences are widespread and prominent. But the state has the opportunity now to take a statewide comprehensive approach to this persistent service gap. We hope to truly change the arc of the lives of the next generation of California and to alter the drivers of homelessness, incarceration, and poverty. It is a bold initiative, one designed by Secretary Mark Ghaly himself, and one that HCI is proud to be a part of. So we so appreciate the vision of Secretary Ghaly and the governor's leadership in supporting this initiative. So I'm going to talk about some of the details of our program. Sometimes that can sound a bit dry as we go through the names of programs and the like. But like you, I do this work knowing that every grant that we make and every application we score is about people. It's about youth and families who live in our communities. They may live in our block, they may live in our homes. They're children and youth that are people that we love who are struggling and who need support. So it's an honor to be able to continue to meet their needs. So the overall strategy of the Children and Youth Behavioral Health Initiative recognizes that we have both an immediate need for increased services to address the acute crisis now and a long-term need for expanded services. And I should say there are many different components of the Children and Youth Behavioral Health Initiative. DHCS is spearheading an effort to build a new platform where youth and families can access services directly, do online classes, do some chat resources, connect with counselors. There are going to be changes in the benefits that are covered by both Medi-Cal and commercial coverage, but I'll be talking specifically about the workforce components that HCI is part of. So again, to address the crisis now, our workforce approach provides advanced training in primary care psychiatry for existing primary care providers serving children and youth. So we know kids are going to the doctors today, and we want to make sure those primary care providers can meet the needs of moderate behavioral health conditions. We are also working to train existing behavioral health providers with effective strategies for serving justice and system-involved youth specifically. We're aiming to expand the number and diversity of behavioral health providers through scholarship, stipend, loan repayment, and earn and learn opportunities. And I want to talk more about the earn and learn model, which is somewhat new for us. We are looking to expand the range of providers through implementing training for community health workers, peer personnel, and behavioral health coaches that can be trained for a short period of time. So we're trying to support existing programs and stand up some new programs to train the workforce that can be trained in a shorter period of time. And then the initiative focuses on the longer term needs by building the educational capacity to train psychiatrists including child and adolescent psychiatrists, public mental health, nurse practitioners, social workers, SUD providers, and others. At the same time, we're trying to train psychiatrists and others with a high level of education. We're also working to build the pipeline necessary to both expand and diversify the behavioral health provider workforce for the future. We're working to create entry points into the behavioral health workforce and develop career pathways to allow the workforce to progress along the pathway. So important to have opportunities for promotion and professional development. Our goal is a workforce with the full range of types of providers, allowing each to practice at the top of their license or training. So I think that's a very important component of what we're looking at, is to help increase the capacity all along, but we need every step of the ladder, again, so that everyone can work at the top of their license. So there are many different components, and I just want to highlight a few. One you may have heard about is our effort to develop a new behavioral health coach professional and to fund programs to train behavioral health coaches and counselors. So the initiative does envision a new category of behavioral health provider. These behavioral health coaches train specifically to help address the unmet mental health and substance use needs of children and youth. So recognizing that those unmet needs create learning barriers, behavioral health coaches will engage and support children and youth in cultural, linguistic, and age-appropriate services with the ability to refer and link to higher levels of care as needed. And of course, that's very important. They'll be members of a care team, and behavioral health coaches, behavioral health professionals serving as coaches will receive appropriate supervision from licensed staff. Their training and qualifications will include psychoeducation, system navigation, crisis de-escalation, safety planning, coping skills, and motivational interviews. Some of the coaches we envision will be in schools and some will be in community organizations. Coaches in schools will support the ability of educators to improve educational outcomes. As someone who's married to a high school teacher, I know well about the huge barriers that kids face in schools, and teachers really need partners in addressing some of those issues. It's critically important that behavioral health coach counselors and the behavioral health school coaches and counselors reflect the communities that they serve and that they can function as trusted messengers and cultural brokers. So we hope to provide children and youth a choice of how, where, and when they receive services, including virtual services that secure privacy and protect anonymity. So as I talked about before, there will be an online portal where folks can log in and get assistance, and then of course we want in-person supports as well. This year, in partnership with subject matter experts, HCI will develop a multi-year plan to launch and implement the behavioral health coach and counselor system. So we are giving ourselves the next year to really do some careful planning, to look at where the existing gaps in the workforce are, and hear from you all about what models would be most successful, what we need to see in terms of certification and licensing and the rest. So we'll be doing a year of planning, and there'll be opportunities to give input. Another piece that I want to highlight is the substance use disorder, or SUDS, workforce. We know that California continues to experience a shortage of SUD counselors and clinicians, and we know that there's a particular need to develop a SUD workforce that provides age-appropriate treatment to youth. The state needs to build a pipeline of SUD counselors and specialists to develop a diverse workforce so that youth and families can get treatment that is culturally and linguistically proficient. This year, HCI will develop a new SUD workforce framework and plan focused on youth and families. So again, this is a large new initiative for us that's going to take some time and planning. The plan we anticipate will focus on several components, including expanding knowledge of existing behavioral health clinicians to provide age-appropriate SUD treatment, such as through train new trainer models. So, we know many kids have coexisting conditions, and very important that people have the full range of training to provide services to the whole child. We'll be providing financial support such as tuition assistance, stipends, etc. for high school graduates and community college students to obtain a Bachelor of Social Work to begin a SUD career serving youth and families. And then we'll be establishing and supporting programs to help registered SUD counselors become certified and train in age-appropriate treatment. We'll be developing SUD educational capacity programs, sustaining and growing SUD workforce programs similar to those that we have today with Song Brown and the WET Psychiatry Educational Expansion Program. We're also looking to expand training capacity for psychiatry and social workers. We know there are significant behavioral health workforce needs in psychiatry, especially child and youth psychiatry, public mental health nurse practitioners, and social workers. The initiative would support and grow residency and training programs that develop this needed workforce. We know that pipeline programs are particularly vital in expanding racial diversity. Studies show that pipeline programs for high school, college, and post-baccalaureate students from underrepresented areas can successfully increase diversity by recruiting and supporting students from underrepresented communities and providing them with a full panoply of support. Positive program outcomes include changes in attitudes and intentions of participants regarding careers in healthcare, their academic performance, and the likelihood they will enroll in health professional school. So we've been trying to do our homework over the spring and summer to identify what are the programs that are most successful, and we know that pipeline programs play a key role in increasing racial diversity of the workforce. The Future Health Workforce Commission report was one of the pieces that we looked to, and it does highlight the need to build a pipeline of healthcare providers to meet California's diverse needs. I also want to spend a minute talking about earn and learn apprenticeship models, which have been shown to be effective in training and placing individuals in needed occupations. So these models provide tuition support and on-the-job training at a behavioral health provider organization while one attends post-secondary school or completes training. The employer would provide a position for the graduate, and there would be a period of service obligation. We would provide financial support to the employer to supervise and mentor the student. HCI will leverage this model to build the workforce for SUD counselors, community health workers, and psychosocial rehabilitation specialists that serve children, youth, and families. So given the racial wealth gap, we think it's critical to have these earn and learn models to support students and give them an income while they're getting the training that we want them to have. As I've mentioned, we also have workforce components to expand training for existing behavioral health professionals, for primary care providers, for example. We're also enhancing training to serve justice and system-involved youth, and with a special focus there. So we do have other programs, but that gives you a sense of the breadth of them. As we work to plan for and support these programs, we want to be very mindful of the varied needs of different groups of youth, including justice and system-involved youth, foster youth, and youth who are unhoused. So we'll be taking a look. We know this can't be a one-size-fits-all model. The Health and Human Services Agency and HCI are really committed to hearing from youth themselves as well as organizations providing services. So we appreciate being in partnership with all of you. Each of our workforce components must be done centering equity and inclusion. We have a good track record of expanding racial diversity in our workforce programs, but we know we start with a workforce that does not at all represent California's diversity. We have a long way to go. So we have some good research showing that our programs work, and we also know we have a long ways to go. So again, we start with a workforce that very much does not reflect California's diversity. We know that psychiatrists in California are largely made up of white and Asian providers, 41% and 20% respectively. Latinx psychiatrists make up only 4% of the workforce, while African Americans comprise 2% of California psychiatrists. The makeup of non-prescribing clinicians is similar. Over half of the workforce for counselors and social workers are white, while white providers comprise 79% of the psychologist workforce. So we have a long ways to go to develop a workforce that reflects California and that can truly provide racially and linguistically concordant services. So we know we have a long ways to go, but that said, our Workforce Education and Training, or WET program, which prioritizes a more racially diverse workforce in the public mental health system, has shown some good results as well as some challenges. The proportion of African American WET awardees who are prescribing, non-prescribing clinicians, and peer personnel, so all three of the categories, our African American awardees are all greater than the proportion of the California population. So we've shown some good success there. The proportion of non-prescribing Latinx WET awardees is also greater than their 40% share of the California population. So we've been pleased with the success we've had with non-prescribing Latinx awardees, but the Latinx prescribing clinician workforce is much lower, not even 10%. So we know we have a long way to go in meeting our goal of a workforce that looks like California. We know it takes time to train a psychiatrist, but it's important to work everywhere along the continuum, and we do have strategies that work over time. So we aren't going to get there overnight, but we are going to use all the effective tools we can. We're excited to have this bold initiative. We look forward to hearing from you and partnering with you and building the workforce that California needs with you, and what a difference we can make together. Thank you again for having me.
Likewise.
Hi, everyone. Welcome back. I'm so honored to introduce this next panel of young leaders to all of you, the first of two youth panels that we have today. The California Health Occupation Students of America, or CalHOSA, is the premier organization for student leaders who are pursuing careers in the healthcare industry. CalHOSA has a mission to promote career opportunities and to enhance the delivery of quality healthcare to all people. You are going to hear from three young leaders from CalHOSA chapters in high schools across the state about what a career in behavioral health means to them and how being involved in CalHOSA has contributed to what they want to do next. I'm going to turn this over to my friend and colleague, Gustavo Loera, to facilitate this panel. Gustavo is the past board chair of CalHOSA and their mental health committee co-chair. For the past 2 decades, Gustavo's work has centered around addressing the existing inequalities that are evident in historically underserved communities in California. He was instrumental in the passage of the Mental Health Services Act in California, and he led efforts to create Human Services Academy models to fulfill the MHSA's mandate around workforce. Gustavo, I'm going to turn this over to you to introduce each of the students, and we are so glad all of you are joining us today.
Thank you so much, Adrian. Thank you so much. And again, thanks to Fred Finch, the California Alliance, for putting this together. I am going to just give you some context. These are students, or the student panelists represent three different high schools, and I think we're waiting for one more student to join us, and two wonderful organizations. The first one is, as Adrian mentioned, CalHOSA. Here we go, Balbai, welcome. CalHOSA's mission is to inspire, educate, and develop students who aspire to become excellent health care professionals through student-led leadership programs. It is a student-led organization that is integrated into the school curriculum. The second organization comes from the Integral Community Solutions Institute, called Mindfulness Club in Sunnyside High School. And their mission goes as follows. We are leaders in raising awareness and the benefits of mindfulness practice, personal development, and higher education. We create a culture of peace and stress reduction through daily mindfulness practice. And they do this through student retreats. So just to give you a little bit of context, these are both leadership development organizations that are in high schools developing our future workforce. And so, and I also want to recognize the advisors of these students. For Brianna Trujillo, who you'll meet shortly, Her advisors are Ignacio Hernandez and Eva Munoz. Again, wonderful instructors who spend a lot of time in developing our students. And again, they will play a huge role in developing our future workforce. Also for Laura Avila, her advisor is Jackie Valadez from Southwest High School. And also for Baobay Lee, her advisor is Everardo Pedraza in Sunnyside High School. And both Ignacio and Eva are at Los Altos High School. So with that, let me start by posing the first question to the students, and then having them in their response introduce themselves and talk a little bit about their background. So let me start with Brianna. Please tell us a little bit about yourself and something unique about your school, but also what interests you in joining Cal HOSA.
Well, hello everyone. Good morning. My name is Brianna Trujillo. Thank you so much for having me this year. Today. I've been in HOSA for 4 years, so I've been in it since my freshman year, and this is my fourth year being NAMI on campus at my school. I'm president currently of both the chapter and NAMI on campus, and I'm also taking a mental health worker certificate program at Cerritos College, and I'm beyond grateful to be able to have these opportunities. I'd like to thank Mr. Hernandez and Ms. Munoz for all the opportunities that have been offered to me, not only me, but to other students within our campus. I think that the topic of mental health is so important, especially being in a Hispanic and Latina populated school. And it's so underrepresented within our nation. So being able to have such an important factor of mental health within our school and campus is beyond amazing. And I generally am passionate about this topic, and I hope I get to speak more about what I've been doing these past 4 years and what has led me to this moment of being here today. And thank you so much.
Thank you, Brianna. Let's go now to Laura.
Oh, hello everybody. My name is Laura Avila. I am a junior at Southwest High School, which is located at the south of California, right next to the border to Mexicali. I was interested in Cal HOSA ever since I came to high school. I didn't know what it was about. I just knew it was about not mental health professions, but health professions in general. And so after finding out that my school had a program like that for students who were interested in the medical field, I decided to enter. And that's where I learned more about the mental health project that our school had, which started a couple years back. And now I am a vice president for community outreach on my HOSA chapter. And in addition to that, I am a founding member and chairperson for a Coalition for Student Wellness, which is a project to raise awareness about the mental health needs in our community, which is really underserved compared to other communities in California. So I look forward to talking to you more about it and sharing it with the other two speakers here.
Thank you, Laura. And Baobay, you've been a leader in actually you've even conducted sessions on mindfulness with various professionals and across the really across the state. Can you tell us a little bit about yourself and also what interests you in being a part of the Mindfulness Club at Sunnyside High School?
Hello everyone, my name is Baobay. As Dr. Gustavo Larrea has said before, I am a junior at Sunnyside High School located in Fresno. So I initially got interested in the Mindfulness Club sophomore year when I had Mr. Everardo Pedraza, which was my sophomore teacher for English. He was also the advisor for the Mindfulness Club at Sunnyside High School, and then in class he would lead sessions and then we would take part in it. And I just realized that after all the mindfulness sessions, I noticed that my mental health was a lot better. I wasn't as stressed, and I just felt so calm and relaxed, and I didn't feel like everything was on my shoulders anymore. So I think that was the initial thing that really got me interested in the Mindfulness Club. So then after that, I joined the club, I attended meetings, and then I feel like after the meetings, I would be more intrigued into this career. So so one thing led to another, and I started leading meditations, and it was really, really inspiring, and it was a really good opportunity to learn. So that's kind of why I was really interested in the Mindfulness Club.
Thank you, Baobay. Let me ask the next question, and I know we're short on time. But this is a conference on how do we build the future workforce in mental health, and obviously we have three future future professionals that will make an impact in our mental health, in advancing our mental health initiatives. From your perspective, why should or why what interests you in the mental health? Why is mental health should be a huge priority in our schools today? Let's start with Laura.
For me, I got an interest in mental health after experiencing mental health issues of my own. After my father's passing in 2016, I experienced a lot of problems when I was young, and even to the point that I got very depressed after all that happened. So after coming to Southwest and learning about the mental health program and learning about the things that were happening to me, I was like, well, students need to know about this more and more. Like, it doesn't have to just include students who are in the club to learn about it. So after that, I realized how important mental health was. And I think right now we have to focus and realize that mental health is in everything. If you want a student to perform well, you need them to have a good mental health in order to do so. And it is important to have underserved communities like mine to have access to mental health needs. I live in a Latina community as well as Brianna. And unfortunately, we don't have a lot of resources here. So what we have to do is spread the word that mental health is something that is needed, something that we need to bring awareness to because it affects everybody, not just students and not just kids in general. But it's something that we need to openly talk about and provide the resources to everyone who needs them.
Thank you, Laura. Bye-bye. What are your thoughts on that question?
Yeah, adding on to Laura, I agree. Mental health is in everything. Mentally healthy children are more likely to be more successful in school and in life. And I feel like it should be a priority because, mental health affects so many things. And it not only does it affect an individual, but it affects the people around them too. Because if one person is feeling down, then people around them are going to feel down too. And sometimes it can lead to the worst case scenario, which is suicide. And I know people who have really close friends who have suicide, and it's so heart-wrenching. And the effects, even after 4 years, I know this person is still he's still experiencing depression from the suicide. So it's really impactful. And I feel like it should be a priority in schools because schools are an ideal place to talk about health, mental health, and to provide help for mental health because this is where most of the mental health stems from. So I feel like school would be an ideal place to, provide help and just talk about it.
Thank you, bye-bye. No, Brianna, I know that at Los Altos, you talked about the partnership with the community college in regards to students being able to get a mental health worker certificate before you even finish high school, which is really amazing. But you've also done a great deal of doing a lot of work on prevention, early intervention, particularly in the early identification at Los Altos High School. Can you talk a little bit about that, and then also just your aspirations in going into the mental health field?
One thing I also like to bring out is this school year we opened, luckily one of our teachers opened a wellness center at our school, and I know as of right now they're planning on hosting different meditations during lunch or after school, and as well as during their 5th and 6th period, we're allowed to go in there if people just need a break from school, since I know many people within high school they struggle through different issues, and you never know a person's background, which is why it's so important to have these have the wellness center, as well as having an open forum to our counselors as well as teachers reaching out to us, making sure that we're doing all right with school. And for me personally, the topic of mental health has made me feel extremely passionate because my freshman year, I actually was able to be fortunate enough to go to a mental health conference in Newport Beach at NAMI. It was a NAMI mental health conference, and during one of the breakout sessions or one of the workshops, I actually had an anxiety attack because I like the personal, like the overall activity of it was like a activity on self-care. It really hit me personally because I don't know, it just like I just felt extremely overwhelmed and stressed with like my freshman year. I just felt like that was like the hardest for me mentally, and being able to see that like other people being there for me who I didn't even know, and being able for them to help me out and like give me tips, and as well as like, you know, calm me down, is what truly made me feel passionate about wanting to help others. Because since if people have like, you know, the heart and like, you know, the overall will to help someone who you don't even know, that inspired me to help other people out, and, you know, make people's days a lot better, since, you know, you never know a person's like background. And yeah.
Thank you, Brianna. I know we're close to the end of time. I just wanted, we have a couple of minutes left, and I just wanted to see if Babai and Laura would like to react to just what you heard from Brianna.
I think it is something that we do need to talk about. Even as students, we need those breaks. Nobody really likes to talk about the stress that we go through or actually recognize it. So it is important that you have that mental health center, and I'll of course bring that attention to my school and see if we could maybe do something similar for our students as well.
Wonderful. And just to let you know, these three students will be a part of the breakout session, so there'll be more opportunity for more discussion. But Babai, let me give you the last word in the last minute that we have. Just your reactions and thoughts about what you heard from Brianna and Laura.
Yeah, I agree. I agree with Laura. I think it's a really great idea. I'm going to see if I can try to integrate this into my school too. And I think Brianna's story is very inspiring. Just to know that you went through that and they helped you is really inspiring. And I really appreciate you sharing.
Thank you, Babai. And something that Babai mentioned, something that I'll do in my school, these three innovative stuff in their school. So again, great leaders, and thank you so much, the three of you. Thank you, Adrian, for this opportunity as well. So I'll give it back to you, or send it back to you.
Absolutely. Absolutely. Thank you all so much. We're going to head to our next youth panel. I really appreciate all of you taking the time. So inspiring, so wonderful. And we want you in our workforce.
Thank you.
All right. Well, good morning. I'm Eva Terrazas, the Vice President of Public Policy and Special Initiatives at Uplift Family Services, and it's my pleasure to introduce you to some of the members of the California Youth Empowerment Network. It's most commonly known as CAYEN, a program of Mental Health America of California. So CAYEN is a 100% transition age youth-led board who advocates for the mental health needs and interests of TAY. In different locales and statewide decision-making spaces. The CAYEN board includes members who all have lived experience with the behavioral health, juvenile justice, and or foster care system. They host advocacy trainings to empower local groups of TAY to reduce mental health stigma and propose specific solutions to support TAY mental health in their communities. I've had the honor of being in a conversation with the board, and I can tell you these are passionate, committed, thoughtful, and smart individuals. So with that, let's show some love for these young, courageous leaders.
Thank you everyone for joining us. Matt here, I use he, him pronouns. I'm the Assistant Program Manager at CAYEN, and I'll be moderating the panel today. And we'll have our board members introduce themselves, starting with AJ, Morgan, then Sophia.
Hello, everybody. Good morning. My name is AJ Arsalus. I use they, them pronouns, and I am from Sacramento, and I am the co-president of the CAYEN board.
Hi, my name is Morgan Huen. I use she, her pronouns, and I am the other co-president of CAYEN, and I live in LA County.
Hi, my name is Sophia Trexler. I use they, she pronouns, and I'm from Fresno, California.
Awesome. Thank you for those introductions. Everybody in the chat, we'd love for you to engage with us. So as you're listening to our ideas, feel free to brainstorm in the chat with us. We love engagement. And so the way we did this is we talked about how do we address the behavioral health workforce shortage / crisis. And we came across a couple different topics. The first one we talked about is how do we counteract some of the stereotypes and negative stereotypes that youth hold about the workforce. by increasing more access to exposure to the workforce. So Morgan, please start us off.
Well, I think it's safe to say that there aren't many opportunities to experience and learn about the behavioral health workforce. If we had policies that would implement career days or job fairs on school campuses and community centers, that would be a wonderful start. Even starting with career days that are virtual or flyers on a bulletin board. And as for opportunities, it would be great to see organizations allowing volunteer work, especially shadowing. Of course, there's that barrier of confidentiality, but we would be able to work around to make sure everyone's privacy is still intact and to be able to give the students and the shadowers enough experience to learn about that field. Another great opportunity would be just more available jobs, full-time and part-time, especially if those jobs were flexible to meet the needs of the busy schedule of students. I think all of these policies would be worked through the system easily enough to make it available for private organizations and even statewide to implement them.
Oh my gosh, I love that idea. If I was in high school and had that, I would be screaming and jumping off my seat. And that really aligns with earlier, one of our speakers was talking about implementing earn and learn programming, right? So we can be shadowing, but also still be getting compensated for our time and our skills. AJ, I know you had some great follow-up ideas with this.
Such a great idea from Morgan. I was thinking something along the same track, that we could have a bill that supports and incentivizes a process for hiring paid interns or hiring paid part-time positions. And I envision a peer support program. So this would need partnerships from orgs who are interested in organizing their professionals, their mental health care professionals who are POC identified, to help other up-and-coming POC youth interested in the field to gain experience, to receive mentorship, and to be able to be culturally matched with someone like them. So I found an example online. It's an exciting new program. It's the Asian Mental Health Collective on Instagram is where I found them. And they're launching a 12-week training program to support incoming mental health professionals by matching them with professionals already in the field and giving them that exposure. And it's specifically broadcasted as trying to recruit other Asian identifying folks. So I want to see this happening with other cultural backgrounds and other racial backgrounds. So that way we can have these beautiful paths that are supported to diversify that part of the mental health career workforce.
I love this. Thank you for that example. I put the name of that collective in the chat for us. And so when I hear Morgan, what you shared, and AJ, what you're adding on, it's yes, let's get these, opportunities out there. But what if I see these opportunities and I feel shoot, I can't afford that, or I think it's too expensive, doesn't pay enough? Zofia, I know you had some ideas on this.
Yeah, so the essential thing is we need to make sure that people feel like they aren't being punished for entering the mental health workforce by giving them a livable wage. Adjusted for inflation, it's somewhere around $25 is what the minimum wage should be today. I would say $20 at the absolute low end. But many of us doing advocacy work live in very expensive cities, so just be mindful of that. Additionally, I had the idea of perhaps doing student loan repayment programs for people entering the mental health workforce. Law schools already do this with public interest law. They will say, go work in public interest law for a couple years and we will forgive all of your student loan debt from law school. So this is a model that could perhaps be implemented either through individual academic institutions or statewide to sort of incentivize people going into the mental health workforce. Because, people could easily go to Goldman Sachs and be paid, egregious amounts of money, but, we need to not be punishing people for wanting to choose a career path that is helping people and is altruistic.
Absolutely. And these loan repayment programs, I know there are some that exist out there, for certain roles. Like I know if I did my master's in social work, there's that opportunity, but I didn't know about that till the orientation for that program. AJ, I know you had some ideas for increasing exposure and getting people's voices out there. Do you want to share a little bit about that?
That we live in a very social media world. I was thinking that we could have a social media campaign. When we're talking about diversifying, exposure is a key part of getting that done. And so we have to make efforts to meet people where they're at. So I would like for us to develop a social media campaign that would expand on different types of mental health care career options. I think that's extremely important. Sometimes we think there's only therapists, and there's a lot of other ways to get into the field. And I would like this to be POC professionals sharing their day in a life when it comes to their work, maybe a summary of their current or past work experience, but also to leave room for sharing like things to be aware of, maybe things you wish you would have known when you entered, right? Sending that love back in the past where you're preparing someone. And so what I see with this, the next step after we get those testimonials from those folks, is that we have to develop a way to make sure that this is spread out to engage POC where they're at, whether it's spaces online, whether it's college campuses, and whether it's high school campuses. So there's going to be an intention to carry out there on how we share the information.
Thank you, AJ. That takes us into our second topic about reaching more BIPOC communities in the workforce. And I saw a comment earlier about like, does this have to do with stigma maybe? What are our thoughts on that? And Morgan, actually, your thoughts right now, I think addresses that a little bit.
It isn't that like people from immigrant backgrounds and BIPOC don't have mental health issues present in their life. They certainly do. It's just riskier for them to join a career that isn't paid as much or has so much stigma surrounding the career path, considering they do generally come from a lower income house. So piggybacking off what Sophia said earlier, the policies that would enforce higher wages during work would be wonderful, but it would also be great to see it persistent through training as well. And also employee resource groups would be a great start to finally diminishing that silent racism throughout the office. For example, spaces for specific marginalized groups that would focus on their personal well-beings and boundaries. It would also be important to state that within these policies, the employees or members of ERGs aren't having to worry about the cost of these groups. Creating and funding for the group shouldn't be a priority when trying to support each other in potentially toxic workplaces.
Totally, and that last point is so big that if there's these support groups or resources for the employees, don't make the employees carry the weight of implementing and creating those, like being able to find the resources to make that happen to support us. AJ, I know you have some thoughts on how we can continue to engage cultural communities.
Yeah, definitely. I think that one thing that I want to see from all of the partners in the room and all the orgs in the room is that we build lists of culturally specific engagement efforts and create a database of sorts or a directory for POC mental health care professionals. So one example I found online, apologies again, it's on Instagram, but it's Latinx Therapy on Instagram. I'll see if they have a website off of Instagram, but they're creating an effort to support Latinx therapy providers to build their own practice. And so what they're doing is they've created a database so that they can signal boost one another, they can offer networking, and they can offer support. And I believe that we should make efforts to support this process where it is already happening, but also on our own pages of our websites, leave space to signal boost, right? Whether or not that's necessarily our field that we're in, maybe some of us are policy primarily, but just to have those resources there, because when it comes to exposure, we need to constantly be trying to support people in that. And another thing, kind of a smaller component, but when we're supporting, when it comes to therapy specifically, making sure that we're leaving space for different modalities of therapy that are coming in. So for me, my experience has been CBT, which is cognitive behavioral therapy, but there's a lot of somatic practices that are up and coming in the field. And I think that somatic practices can be really helpful for different culturally specific, because it could help them to be engaged in a different way. And I wonder if it would push back on the stigma of, well, I don't want to talk about my feelings. Instead, it might be, okay, we're going to work with your body and see what that means about your feelings. So those are the two things I'm thinking about.
Thank you, AJ. Love that, and seeing a lot of love in the comments. Just a heads up, we're gonna go like 2 minutes over our time. So thanks for, holding this space for us. And I'm gonna pass it to Sophia. I know we talked a little bit about burnout and supporting behavioral health workers, and you had some really great thoughts to share on this.
Yeah, I think one of the most important things is making sure that people don't feel like they are feeding into oppressive structures of power that we all know are pretty inherent in the mental health care system, and creating positions that don't feed into these oppressive structures. One of the main ways to do that is to take away the involvement of police from mental health and responding to mental health crises, reforming psychiatric institutions, looking at state hospitals and majorly restructuring how those are and how people are treated. A couple ways specifically for removing police away from mental health is mobile crisis response teams, which is SB 988, and peer certification rollout, which is SB 803. I see some of you in the chat who I know are very involved in those two pieces of legislation. I'm sure you don't need reminding how important those are. But yeah, reforming psychiatric institutions, because what happens is we are getting these people who have lived experience in the mental health workforce. Sadly, once you have these terrible experiences, it's really unlikely that you're going to want to be in the mental health workforce if you feel like you are going to be actively causing harm to people. Creating positions that aren't terrible is the main priority. And that way we can focus on having a mental health workforce that is diverse and progressive, and also understands mental health, perhaps because they have some lived experience in the system. And then there's also the need for preventing burnout and supporting people who are actually in these roles. One solution is to pay for the mental health care of your employees, but that's more reactive and not preventative. It can be preventative, but the goal is not to create roles where people think that they are going to enter a job where therapy is just if they know that they're going to need therapy as a requisite of their job. One solution that could be great is, just amping up broader employee supports like healthcare. Morgan brought up ERGs, but just make sure that your employees know that they have a substantial list of benefits and that they are supported in the workforce. Of course, everyone's needs are individualized, so it's up to you to look at your organizations and determine the individual needs of your employees and sort of work on how to do that inside of your organizations. But wellness and preventative resources are really the key. Again, we are nonprofits working for mental health, and it is somewhat hypocritical to bring people into the mental health workforce and ensure that their mental health needs are not taken care of, or that they are so economically unstable that they are stressed out all the time, or that they can't afford healthcare, or that they can't afford their mental health care. So I think that's really important.
Absolutely. So now you know why they call us Cayenne, like the pepper, we pack a punch. Thanks for listening to this panel with us. I couldn't resist the dad joke, sorry. But yes, there's so many great ideas on how we can address this behavioral health workforce crisis, and I'm so excited for these breakout rooms coming up. I hope you really take into consideration what this panel has been talking about, what the previous panel has talked about, and all of your expertise to really think through how can we address this workforce shortage, this crisis. We're really excited to see the ideas that come out. I'm really thankful for this time together. Thank you, everyone.
I'm Luis Torres. I'm the founding dean and professor in the School of Social Work at the University of Texas, Rio Grande Valley in Edinburgh, Texas, right on the US-Mexico border. And my task is to kind of launch us into our afternoon breakout groups. And I just wanted to take a couple of minutes to kind of give us our charge. All of us have been in plenty of conferences of this kind where we diagnose and re-diagnose the problem and we hash it and we rehash it, and then we leave without any clear direction of where we want to go next. We want this to be a different type of experience. What we are asking of the groups that are going to convene in a couple of minutes is to come out of those groups with some actionable items. You know, not pie in the sky, not let's change the world overnight. We heard some really good things that are already being done in California from some of the presenters this morning. We want the groups to think about those things and add to them. And when you do your report, when you come out of your small groups, put a couple of things on the table, 2 or 3 things that we can get to work right away, what we call sometimes low-hanging fruit that can be implemented easily, that are feasible, and that can have great impact starting from the get-go. So that's the task, right? So the task of the small groups is not going to be to save the world or change the world. We all want to do that, of course. That's why we're here today, but that's very difficult to do. So we have to figure out how to achieve incremental change. So let's go to our small groups in a couple of minutes, and let's start thinking about what are those actionable things that we can do, start working on immediately to actually impact workforce development and workforce availability in mental health in the state of California.
There were a lot of different ideas that came out. You'll see that on this first slide, there are thoughts about how high school students were actually able to do more shadowing virtually, so long as we could be mindful of confidentiality. Recommendation to do a lot more community engagement like what Cal HOSA is doing into more schools to educate on stigma and risk factors. This is, I'm sure, something that's been said plenty already. In terms of paid internships or stipends being absolutely necessary and asking the state legislature for this. And then the size of the payment, there's an example at the end of that slide. And we're going to keep going because we've got about several other slides and lots of ideas. Hopefully, let's see. Hopefully folks can see the second slide now. And a couple of ideas, amazing examples, but some of the things that for example, UCLA is doing with special advisors and really focusing on reconnecting to rituals, celebrations of life, witnessing the contributions of those we've lost to COVID. And that could be a route in for more workforce. Definitely helpful to have volunteers getting trained as peer specialists and getting more community-based and grassroots organizations involved in as peer specialists or as other types of workers. In Alameda County, there's an example of that. And then there was a second example of the Invisibility Project, which is helping, and that's from BizStoop. That's Desiree's, who's unfortunately not presenting this, helping the Black community to engage in self-care and be able to show up in their own bodies despite all the historical traumas they've experienced or personal traumas. Caring for themselves, not just for others, and bringing in the folks to help to heal them whom they feel are healers, not just who's defined as a healer by more dominant society or structures. For internships, had some good conversation about that, needing to be safe spaces, and recognize that there are definitely cultural differences and challenges that can make people feel incredibly excluded if they're coming into contact with Western Eurocentric cultures. And so we really need to update the healing systems to take that into account. It really matters for interns to see someone who looks like and sounds like them. Alrighty. Great conversations about incorporating traditional practices and supporting practices that are somatic, not just CBT or cognitive and behavioral oriented approaches. How can we update our traditional practices to fit with today? Great example of a sweat lodge ceremony and coming of age ceremonies. And interesting that the traditional boundaries around holding a sacred space are very, very much in alignment with the confidentiality guidelines that are part of the existing formal mental health system. Questions about evidence-based. Whose evidence? What is it? What practice is beneficial for whom? Who's saying that? And there's a lot of rich evidence when we start to look at mental and spiritual and physical health practices and more traditional knowledge. Pointing out that there are a lot of state initiatives right now that explicitly focus on evidence-based or promising practices. And it's really important that we use our collective voice to clearly describe and promote our own community's practices and customs that work, and really expand the definition of evidence-based evaluation. And using, we can certainly apply the principles of what gets identified as evidence-based to our existing traditional practices to bring them to the forefront and gain mainstream acceptability and everything that comes with that. But really shifting how we talk about what's evidence-based. We talked about community-rooted leaders as a resource, building connections between mental health and faith leaders, really helping people to share their stories to counteract stigma. The elder community who often care for their grandchildren is also a huge resource. Also another group to educate about what mental health looks like or mental health symptoms, so that they can help get people to help. Definitely there's a big barrier for people to successfully get into the mental health field when they're themselves recovering, or they're survivors. And our whole workforce deserves affordable treatment from experienced professionals. We really need long-term funding for innovations. We need community champions to get the necessary healing and the training. We should really be investing in bridge builders who speak multiple languages, the language of their community, and also potentially the mainstream languages, and bringing in informal healers. Definitely talked about the systems right now being very extractive in nature, and that we need to build and strengthen a restorative and sustainable alternative for the long run. We definitely need to invest in our communities, those informal leaders, all of those things. We talked about youth and community as experts. Couple of examples of cultural responsiveness, considering youth language, which is constantly evolving, pathways for youth, the importance of recognizing the emotional labor of family members who are caring for their another family member or members. Another great idea is happening again at BizStoop, conducting heritage events where peers and allies are designing these events, and they can be both healing and they can engage members of a community in mental health. Storytelling events, storytelling especially about resilience, is an important strategy and helps to develop protective factors that can help to prevent later issues, and reaches out. It's an outreach strategy, a recruitment strategy for our workforce. We talked a little bit about having sufficient funding across both public funders and private foundations, that it's really, really necessary both for internships, for loan payment, for educational fees, all of that. And also the necessary administrative support so that interns and people newer to the field and people who've been in the field for a long time have the necessary supports so that they can succeed and not burn out. A really fascinating idea about creating a 59th county. This is a very transformational idea, and certainly would be interesting to see how this plays out, about creating this 59th county that could basically create a mental health system that is focused on traditional healing practices, but is integrated into the current more structured payment system. And a lot of questions arise about what it looks like when these two cultures bump up against one another. And like, how do you bill for a sweat lodge? What's the rate for that? How do you credential a more traditional healer? So lots of great questions and ideas there. Almost to the end, talked about more training for teachers so that they can identify youth who might need help and know how to get them to help. And that should include after school program staff. And lastly, a couple more examples of supporting the workforce. Definitely need supports for when the healer needs some healing. And also another example from UCLA about making sure that people know how to get others to help. What's the clear pathway to getting services, and how do we make sure that our broader workforce, not just the mental health professionals, but everybody understands how to get people to care. And with that,
thank you so much. We had just an outstanding breakout session. Our key stakeholders were Dr. Luis Garcia, Dr. Francis Su, Dr. Deborah Berkran, Dr. Nola Butler-Bird, and just an outstanding high school student, Bayao Bei Lee, and we really opened it up for our community members. From the earlier youth panels, especially the Cayenne panels, we heard Morgan and as well as Zofir talk about the stigma and discrimination in mental health. We all know that people are dying 25 years younger due to stigma discrimination in mental health, not due to mental health diagnoses, but due to obesity, cardiovascular disease, and diabetes. And that stigma and discrimination also impacts our behavioral health workforce. In ways in the reimbursement for the services that we provide, our recruiting and our retention for behavioral health providers, and we don't have equity with our healthcare providers. So taking our challenge from Dr. Teresa Chapa this morning about how can we create a pipeline where we can bring more culturally and linguistic workforces, one of the key things that came up was really exposing students in high school, community colleges, baccalaureate programs, and graduate degrees. But exposure is not enough. We need to decrease the economic stigma about going into mental health, especially if you are from an immigrant community where you, I think it was Dr. Butler-Bird or maybe it was Dr. Deborah Berkran who talked about hierarchy of needs. When you're looking to put food in your stomach, you're not looking to go and get higher education. So we need to put economic support to expose the youth and people in community college and college so that they can see that there's a sustainable pathway to a reimbursement. So that was one of our key takeaways. Also, there's a lot of conversation about once you do go get a master's in, let's say, you're licensed, we talked about nursing and psychologists, but there's a big disparity with the Board of Behavioral Sciences as well as the California Department of Health, is that you've gone to school, you become an LCSW, you become a licensed marriage family counselor, you become a licensed certified professional counselor, and by regulations in care settings, there's areas that you can't work in. One of the examples was given is a freestanding Title 22 psychiatric hospital. Only LCSWs can provide there. Another example was a general acute care medical hospital where you're seeing total population, but they're only allowed to hire MSWs. So really looking at how can we get equity across the Board of Behavioral Sciences and having California Department of Public Health create or loosen the regulations so that we can bring more diversity and more licenses can work in those environments. A big one that came up was peer support. We're very excited that SB 803 got passed. We know California was one of the last states to get it, and we know that's going to be a pathway to not only employment in behavioral health, but likely to increase culturally and linguistic services. But as part of that, we really would like to amend or make a recommendation to the legislator to amend SB 803 to allow for tuition reimbursement and loan repayment. So if you become a peer specialist with and become certified in that bill, we know that we have somebody who has a passion for behavioral health, has a passion for healing others. That would be a perfect workforce that the state could then incentivize them to get higher advanced degrees and licenses. Another one that came up to us from one of our community members is we have people from other countries that make our country so diverse and great, and they have higher education in those other countries. But if it's the Board of Behavioral Sciences, the Board of Nursing, California Medical Board, it is arduous and near impossible for them to get the licensure that they practice in their other countries. So one of our members talked about they had an advanced degree, but they were working at a lower level, even though they had the advanced training in another country. And when we're looking at how do we create that pathway for a diversity, culturally and linguistically, and that we have a dearth in behavioral health providers, this seems to us as an option that we could really change the form and function and truly highlight the diversity, equity, and inclusion that California many times is so proud about by allowing a pathway that is not burdensome for out of country providers. We heard so many stories over the years of somebody who was a physician who started as a mental health worker, then one got their CNA, and then that got their RN, but it took them maybe 10 to 15 years to do that when we need providers right now. Another one that came up from our members, and then also Dr. Luis Garcia, is that there's competition among behavioral health programs. So many times in California, it's called the 58 states of mental health in California, because the counties dictate who gets access and who gets services. And much time it's done by your zip code. And the counties aren't managing a continuum of care, they're managing programs. So two programs who are looking to collaborate together may actually be competing for an RFP, so that's not collaboration. So is there a way that we can create standards where we not only are collaborating on the care for our patients and the continuum of care, but it's not economically fighting one another? And there's a lot of good examples of one program may have a client panel of 60 and another 30, and so many times there's going back and forth depending on the payment with the same programs within the same counties. So these are some of the 5 things that we distilled as takeaways to really meet that challenge that Dr. Teresa Chapa said this morning about what could we do to change our pipeline. And then, of course, we went deeper with very robust conversations of looking at how many hours it takes to become a licensed clinical counselor or a social worker, the stigma and discrimination that not only impacts our patients, but impacts the workforce, especially if you're from an immigrant community where you're looking to support your family. Is there that economic pathway where that family can feel proud of moving forward and be sustainable? That was a big conversation in our group, and just really the importance of exposure early with mentorship for our youth so that they can see a career pathway using social media and innovation to really highlight the programs and following up. And then I'm sure these slides will be available, but really the importance of looking at how we can have more standards and operate as a continuum of care across California and not limited by zip code and the 58 counties. One of the big things that we also were very inspired by at this conference, and we're grateful, is truly the youth panels and how important that they were talking about the structural of how we need to work on the reimbursement for behavioral health and the salaries so that we can bring the youth into our workforce and elevate our practices. So thank you all very much.
We had a very robust conversation, as it sounds like everybody else did. This was a wonderful way to get some very diverse and rather consistent information about how to improve our systems. The major ideas and innovations were that community-based knowledge should drive the care of our communities. And that's a very important thing. I'm going to say it one more time. So community-based knowledge should drive the care of our communities. One of the things that we do very well is decide what should happen in our communities, and that really needs to be reversed. Since mental health needs are complex, the type of worker and the skills of workers that need to be employed need to be equally complex. So limiting services to schools, to a school counselor, is not going to meet all the needs. Expanding it to multiple people and multiple types of services is more likely to provide services to our various communities. We need to begin to change the hiring processes and the workplace practices to better accommodate different roles and different expertise. One of the things that we spent significant time about is hiring peer support specialists and hiring them into a system that accepts them as peer support specialists with expertise, not requiring them then to go further and get further education, because the expertise that they have and the training that they already have provides a professional service. Thank you. Four, CBOs and systems need to recognize the value of lived experience, which is along the lines of peer support specialists. One of the things that we do know is peer support specialists may be required in terms of new contracts and new service delivery systems. However, there isn't consistency in who is providing, in the jobs that they are doing. So a peer support specialist who has a very specific skill set is being asked to do something outside of that skill set. Answer the phones, be a translator, other things other than what a peer support specialist is trained to do. So everybody needs to understand what those jobs are and what's involved in those jobs and what expertise is required. Everybody can't be a peer support specialist. CBOs should work with counties to reform contracting requirements. Sometimes the requirements for service delivery is so restrictive that you can't hire a peer support specialist in a position or a person who doesn't have a license in a supervisory role or a program manager role when that person would be perfect for that role. Sometimes we're asking for, when we're providing services, we're asking for people who have lived experience in a particular area, substance use, justice system, and the individuals aren't allowed to be hired within your system, requirements or your own hiring requirements. This is said earlier differently by the two previous groups. State and counties need to expand supports and mental health workforce in education. If we're going to have more people, we're going to have to provide more supports, and supports that match the communities who we're trying to hire or recruit into the system. This seems like number 7 seems like a no-brainer, but we have a tendency to reinforce not providing services to very specific communities. So states and counties need to address the inequitable service access and delivery for tribal communities and members. We often will say in our various counties that we're providing services to the people in our community or diverse communities, and we sometimes leave out tribal communities. When we say we're meeting the cultural needs of our diverse communities, we often leave out tribal communities. And there needs to be a actual voice heard on a regular basis that says, and the tribal communities, to ensure that we're meeting that need in particular.
Benefit. So in our group, we were focusing more on the immigrant refugee ideas, how we can make all this better for the community and mental health and future professionals. So in the team, we had Brent Taylor, myself, Lupita Castro, Carolina Valle, Beatriz Lee, Laura Avila, and Matthew T. Some of the ideas, so I'll start with the number 1, is helping organizations who pilot to have sustainability. So as all of you know, funding is the issue. Sometimes we start one of those projects. We are so excited. We just have so many great ideas and they work, but most of the times we have to stop them, projects or benefits because of the lack of funding. So that's one of the things that we're really looking into, getting that support to sustain those awesome projects and benefits. Then the number 2, the legislation recommendation, the Senate Bill 988, this about the mental health crisis hotline. And as we know, we're moving forward, to launch this by mid 2022 next year. And having, this great opportunity to link all those in need of a mental health counselor or practitioner and link those people through this universal emergency number, the 988, and break those walls, for people to get the appropriate treatment, especially when we're talking about a crisis situation, and those opportunities that we all can have as the different organizations. And I'm gonna just use an example on mine because I represent a community college, and having these ideas that we've been brainstorming already of putting those numbers, the crisis numbers on the back of the student IDs, having posters, having different flyers via social media, and or the different routes that we can get the students' attention to promote, which is going to help 2 areas. Number 1, decreasing the stigma, and number 2, to have that accessible and really easy to get on those numbers that they need. But once we get all this launched in across the country, we can say, that's gonna work like a 911 number, and we will all remember this in those emergency moments. Then the number 3, establish connections between high schools and community-based organizations with institutions of higher learning. So I was so thankful that we had one high school student representing, that feedback on our group. And it is so awesome how students or the youth, especially talking high school students now, they see the world of mental health, from this different spectrum as the current students, and how they want to implement and do better, to promote mental health awareness across high schools, as also how they are, just working by volunteering, getting involved in the different school projects, mental health related, or campus clubs. Like in our college, we have Active Minds, and all those different opportunities to create clubs and also chapters that they are recognized nationwide to promote more mental health awareness and benefits for students. But at the same time, we are helping those high school students to really get, the practice, how it is, looking into the area of mental health, and how they also can learn that in case if in the future they want to go or continue into that direction for future professionals into this field, how they are already starting, the practice, the volunteer experience in their resume, and at the same time they are getting like a mentorship in a way from all the different other resources that they are promoting for mental health awareness. And then also, having that communication between the higher ed and high schools, so we can promote more opportunities also for education. Some students, they don't really know what it is, this field, and we can, as working in those institutions of higher ed, we can start, educating more of those high school counselors or students in these opportunities. And then number 4, create more non-degree based jobs as well as community-based jobs versus the clinical-based jobs that we all probably have been talking before about as part of the mental health team. Okay, so we were discussing, and I heard some of the other groups too, talking about this other umbrella that we see the needs and how these, merge together between the mental health needs, the basic needs, and also, the wellness in general, which is the mind, the body, and the health, the medical health. So all those aspects, in a combination of getting all those kind of wraparound services that sometimes they don't need to have a clinical degree, and they will benefit, by all of us, creating opportunities for those who can serve, under the social services or behavioral sciences degrees umbrella, kind of, to be able to communicate, support, link people, with resources. But at the same time, if, getting, their wet feet into the mental health profession in case, maybe why not in the future, they want to continue more clinical. And then number 5, pay for mentorships, internships, trainings, apprenticeships, and all those similar opportunities. I know it's, again, the funding is an issue, to pay for those opportunities, but obviously that will help if we have the funding that we can all support, based on the different agencies, those opportunities for these students and future professionals. Number 6, community health programs, promotoras from high school and beyond, just going out there, providing these resource tables, communicating. We were talking about, these representatives, like I have had before, wellness ambassadors as well in this college, and how it's so attractive for other students and even community members not familiarized with mental health to listen from them, to listen from those students, high school students, college students, and what are the needs, the benefits of these health programs and mental health programs, and present, through the different routes like social media, even radio shows, podcasts, and all those opportunities to promote what we can do through those community health programs. And then create opportunities for leadership in high school or college, And I think it's kind of what I have already mentioned, and we were focusing a lot on that. Opportunities for them, we know we have under education the associated student government programs at high school or college, where they can take the lead, not only on what it's really like matters of academics and other projects going on the different schools, but also incorporating mental health as part of the governance group, and also be a support for it and other programs. Is the time running out? No? Okay, I was like, okay, I saw the camera, sorry. And then create, measure what matters. Okay, so we were talking about decolonizing the system, changing the outcomes, because honestly, and I have worked at different organizations before a college system, and honestly, as everyone knows, we're really focused on the productivity, what matters, the paperwork, in terms of how we want to continue getting the funding and all those mandates that we know for sure, documentation and requirements. But at the same time, promoting out there for the community, for who we work for clients or patients, and talking, changing the conversation about what mental health is, in the matter of, it's not really just about diagnosis. And I used to tell my patients, you are not a label, you are not a depression, you are not an anxiety. It's more about talking, more on their language, and representing mental health on the sense of it's about taking care of yourself, and not only the patients, but also our team members, people working as the mental health providers. And also, how we really present or promote mental health, because we don't want to scare people out, by saying, oh, it seems like you have a mental illness, or welcome to our mental health presentation. So we don't want to really, talk in those terms. We just want to say, hey, there's this, topic of wellness going on today. You are invited to listen to these important tools that you can use to take care of yourself, or things like that. So it's a matter of how we're going to be breaking down those ways of promoting for our patients, for who we represent and work for, and also for who we want to really bring into the systems as the future professionals. And then number 9, it's change the rules on the limits of FAFSA funding and the availability for adult students without a high school credential to access state and federal financial aid. So with this, it's, I don't know, some of you may be familiarized, but since we're focusing on an immigrant and refugee, sometimes, and especially I'm going to talk on my geographic area, I'm very close to the border with Mexicali, Mexico. And a lot of people come with a, let's say, bachelor's degree, una licenciatura. They come with a degree from Mexico, but they cannot find a work here in U.S. because obviously that is not valid, as they can perform, clinical work or similar here, even if they are psychologists in Mexico, and they don't qualify for financial aid opportunities. Why? Because they have higher education and they're supposed to have a job already. So that's something that we may want to look into it, because we may have people with great experience from another country, but they really cannot get into a way of helping other people here in the U.S. or getting into continue their education. And then number 10, social media, of course, and especially now with COVID, as we all have kind of become more experts into technology. Social media has been amazing so far on my experience and what we were sharing in this group. Using those ways to promote for mental health, for all these, many benefits, and promoting what we offer in our agencies and all those employment opportunities that we want to offer to our community and professionals or students out there looking for those opportunities. So I think that's all on behalf of group number 4. Thank you.
About pipeline in STEM, right? There's so much that we invest in the STEM pipeline, not just from high school and middle school and elementary school, I don't know how many of you know that the National Institutes of Health actually has scholarship opportunities, grant funding opportunities for high school students, middle school students, to start getting them in the mindset of researchers. And that's really, really important. But we need to do the same thing with people who are going to be providers, particularly in areas as critical as health. So every single group talked about this pipeline. The other thing, though, is to make the work valuable by not expecting it for free. So these pipelines are really, really critical, but we have to pay them. We have to provide stipends. We have to teach them early on while they're learning the content and developing the passion to work in this field. We also have to to begin to communicate to them that it is possible to also make a living in this field, right? I had a supervisor many years ago who used to say that it is possible to do good and to do well at the same time. They're not mutually exclusive. And somehow we have perpetuated this myth that if you focus on those careers that allow us to do good, to work with and for our communities, that you're going to have a lower standard of living. So, that starts by adequately reimbursing our volunteers, our interns, and providing stipends for them. The other piece that came up, another piece that came up repeatedly, and all four groups touched on this, is this piece about peer specialists. And we call them different things. Different groups call them different things. Promotores o promotoras de salud. We talked about community health workers. We've used the term peer specialists, people with lived experiences. All of these terms were actually used by the members of the four groups to refer to this group of individuals that may not necessarily have advanced degrees or licenses. That may not be what they want to do, although if they want to do it, we should provide pathways for them to do that as well, which was another point that came up. But these are folks who are from the communities that we want to impact, that know the communities well, that know what the communities are struggling with, and that can actually, as we say, hit the ground running. So we have to invest more in the training of peer specialists and support them both with training, financially, and recognize the tremendous value that they bring to our work in mental health with communities. I loved this point that the first group talked about this, and two other groups actually touched on it. But this piece about self-care, which I'm in social work, and obviously we talk a lot about self-care, and oftentimes it's just talk. It's just empty talk. We take pride in the fact that in the social work profession or in these non-degreed professions that I think Lupita mentioned in the last group, that the minority communities are disproportionately represented in these communities. In one sense, that's a good thing because we understand our communities and can work with our communities. But in another sense, it's not, because we somehow get brainwashed to always be in the role of the caretaker and never think that we need care as well. So we have to shift this conversation to really focus on the fact that you can't be a good caretaker if you're not taking care of yourself, right? In my family, we used to say, la caridad empieza en casa, right? Charity starts at home. You take care of yourself, you take care of your own needs, and then you're in a position to help others. The last thing I'm going to say about this last point, which also came up in all the different groups, is this piece about the overemphasis on evidence-based practice. And we talked about, whose evidence. We know that many of our communities are not well represented in the studies that provide this evidence. We also know that there are good interventions that are originating from our communities that are showing promise, and that the people and the organizations that are developing these practices maybe don't have the infrastructure or the support to evaluate them so they become evidence-based practice, right? So we also have to support, another group talked about supporting the people who are doing these pilots. We have to support organizations that are coming up with homegrown, community-based approaches and interventions, helping them evaluate it, helping them find the evidence, so then they can be labeled as evidence-based practice, categorized as evidence-based practice, and partnering with the community to make sure that we're measuring the right thing. That's another thing that came up, that oftentimes, you know, we're measuring the wrong things. Can we go to the next slide? Oh, I'm sorry, hold on. I told you about my kid. Peaches, get out of here. She's gonna hit the keyboard and mess everything up. The past year and a half has taught us humility, you know, when technology gets the best of us, and it has also taught us to coexist in a more intimate way with our animal companions at home, because they come and go as they please, no matter what we're doing. The second slide, I highlighted a couple of things that really called to me this piece about connecting to communities. You know, many of us here are academics, researchers, providers, etc., and we tend, just like we do with the evidence piece that we were just talking about, we tend to take a top-down approach that, you know, we know what's best for our communities. Peachy, you gotta go. We know what's best for our communities, and we don't check in with them. We don't let them tell us what it is that they need, how they want to address their issues. So we have to really forge genuine connections to our communities, to faith-based leaders, to community leaders, to the elderly. Youth voices came up multiple times. We heard some extraordinary youth voices this morning. Tribal communities, right? A genuine partnership. We like to drop the term community-based participatory research in my world, right? But it really isn't community-based participatory. It's still the academic thinking that we know more and telling the community this is what we should do, right? It's not a true partnership. It's not a genuine partnership. I love this piece about storytelling as a way to promote resilience. So often we focus on the deficits, on what's wrong, on what needs to be fixed, and not on what's working in our communities that can be built on and expanded to other areas, right? So promoting resilience. And then this piece about mental health aid for everyone. Right, mental health first aid is something that we should be teaching everybody to identify signs and symptoms of mental health problems, to know how to talk about mental health conditions or mental health problems without stigma, without fear, to know what to do when somebody needs help. Those are some of the things that you learn in these mental health first aid trainings, and we really got to blanket it. That's a low cost approach that can really make an impact, because the more people in our communities know about mental health, the easier it becomes to talk about it, to identify when we need help, and to connect with help. Can you move to the next one? I'm almost done. Some of these points I was just taking. Again, the pipeline again, the peer support again. This is an important point that two or three of the groups actually talked about it. A more expeditious pathway for the many highly trained immigrants that are here among us, that want to do so much for their communities, and that they're not able to practice, despite the fact that they come with degrees from their countries of origin. They have tremendous practice experience. They speak the languages of our communities. They understand our communities. They have the cultural grounding, but they're underemployed. They're working in areas where they can support their families, but they're not able to have greater impact in our communities. So we need pathways like that, and not a pathway that takes 10 years, like one of the presenters said. I mean, those pathways exist, but our communities need help now. I remember many years ago when I was doing my graduate training in New York City, the New York City Health and Hospitals Corporation had developed a training program for physicians from other countries that were brought in, and once all their credentials were established, they could shadow physicians that were licensed and credentialed in the U.S. and begin to be able to learn not just English, but the medical language, the laws that regulate the practice, so that eventually they could actually take a licensing exam and contribute. So that's just one example. But I had in Houston a few years ago, a colleague from El Salvador who's a psychologist, and who in El Salvador was actually a leader for one of the Ministry of Health programs that was serving some of the most violent communities in El Salvador with mental health. They had these teams of multidisciplinary teams that had a psychologist, a social worker, a psychiatrist, and an art therapist. And he created this program, and he ran these programs. And then he came to Houston, and he was working in a dealership washing cars because he was a psychologist in El Salvador, and he couldn't get his degree validated here. It's tragic. It's tragic for him and his family, and it's tragic for us that we can't come up with a way to allow these individuals to do what they want to do, which is contribute to our communities. Can you go to the next one? I think that I talked about this one again when we're talking about the focus, the overemphasis on evidence, right? What about the evidence that's emerging from our communities? How do we make sure that evidence comes to the surface and is evaluated and positioned to make a difference? This group talked about the peer specialists again and again and again. And then finally, the final group, which was Lupita's group, re-emphasize the same thing: the pipeline, the peer specialist, the assigning value to the people who are doing this work from the time that they're volunteers, right? Stipends, teaching them to value the work, and then the holistic approaches to health and mental health, the incorporation of traditional practices. So I am going to, the last one, if you can go to the last one, which is really important. We talk about this a lot in social work, recognizing that diagnoses are labels and that labels have power, right? We need to assess, we need to diagnose in order to treat. Unfortunately, we need to do it in order to bill, but we have to recognize that these diagnoses are labels and they take a life on their own, and we need to destigmatize by changing how we talk about mental illness, how we throw around the labels. I still hear colleagues of mine, brilliant and well-intended, who talk about schizophrenic patients as opposed to patients with schizophrenia, right? We don't do that with people with cancers, or, we don't say, I have a cancerous patient. I have a diabetic patient. I have a patient with cancer, I have a patient with diabetes, but it's okay to equate the individual with their mental health label. We have to move away from that. And then finally, I love this point that Lupita made about social media campaigns focus on career options. We see a lot of this in the STEM field. We see a lot of social media campaigns in mental health focused on destigmatizing and focusing on looking for help. But I've yet to see one that focuses on, are you interested in a career in mental health? And this is what these careers look like. This is how you can get into this field. These things that the groups have talked about are not earth-shattering. They're not things that require our government to grind to a halt and find the budget to do these things. Many of these things are already being done, and we can be smart in the way we invest in these initiatives.
And I want to thank everybody. We ended this section a little bit earlier, and so I just wanted to make sure that everybody felt heard. If you would like to make some comments right now or have a brief discussion, I want to make sure that we have space that offers that.
Hey, Teresa, can I add?
can I add a couple comments?
Yes, please.
Hi, everybody. Somehow I clicked the same way. I got it back in earlier, and then it popped up on the whole screen. Anyways, I also want to remind folks that I know like there's a lot of emphasis in peers and also master level clinicians to be trained into the system. And as a psychologist at a doctoral level, I have many peers and know many people who want to also get involved in the public sector to help the communities that they come from. But unfortunately, the systems don't really hire doctoral level clinicians. So from my perspective, there's really a discrimination, and there's not really the inclusion of all the qualified mental health providers to be able to provide to the population that we're trying to serve. Yes, there are many more master level folks, but there are also others who are coming from minority communities who speak the language and want to give back, but they're also interested in other parts of the training that oftentimes end up having to go into like private practice or some other private hospital settings, rather than really going back to the communities that they actually are wanting to go back to. So I know that the BBS is much bigger than the BOP, or the Board of Psychology, but I always want to make sure that people remember that there are psychologists out there who really want to work with the public. So myself being one of them, nonprofit all the way. So.
And thank you. And I think we need to say to each other, for those of us who are, in the nonprofit world, many of us, even if they're in universities, which could be also nonprofit, but even if they're in universities, give a lot back to the communities. And so many thanks to those individuals, all of you, which is why you were selected to participate, because all of you who are here today are those who have given back and who constantly and continuously give and think about how to serve, but also how to bring other people along. I mean, this is really what this is all about. And I know it's hard to have one distinct conversation about building a workforce without recognizing just what the world of mental health, what it means to us, well-being, mental health, the careers, the whole gamut.
Teresa, one more thing, and I'll be quiet. I think the other thing, I know like many of us who do have higher degrees don't mind addressing ourselves much more informally because we're amongst friends and colleagues. But one of the things that I've also learned along the way is that many cultures do respect education and also professional titles, and they're actually much more open to following what the doctors would say. So I've always made it a point to really address myself as Dr. Jorge Wong and teach my students to really address themselves by the title, because it really does bring a sense of credibility. I mean, we have people argue against me about, is it like a power differential? And I would say, yes, there is a power differential, but how we, from the doctor's perspective, treat the individuals that we are working with, or respect them, understand culturally age differences, but also understand that we do bring an expertise that can help them, and they can also appreciate that piece, would not only have them understand the value of for the mental health perspective and the providers, but also gives the younger generation the idea that, hey, that there can be a doctor that is valued within my family, within my culture, that I can actually pursue, and it actually is a good way to do good and also make a living, as Luis was talking about earlier. So I do want to remind folks that there is value in really modeling for our community that people that look like them, speak the language, came from the barrios, the ghettos, the Chinatowns, that really you can actually make a living and become a doctor and really have a respectable and helpful kind of a career to really allow the families to really understand. So I just want to throw that in.
Thank you so much for that point. Well taken. Agreed. Would anybody else like to add some conversation? I'd love to hear from you, even how you felt the day went. Okay, yes. Nola, are you going to speak?
Manola, yes. I'm only going to reinforce what has already been said, and that is that I think when you bring people together and allow them to speak freely, they come up with all the things that are needed. And I think this has just proven that there's enormous amount of information here and tools and practices that could be put into play.
Nola, welcome.
Yeah, I just wanted to thank you, Teresa, and
the whole foundation for everything that you did, putting this together today. You know, we're often these silos, you know, huddled in our little areas, often complaining about various things. And so having this kind of cross cultural and cross institutional opportunity to talk to each other has been really beneficial. My niece died recently after a long battle with mental health issues, and so this has a really intense personal meaning for me because she was in higher education. We had tried everything we could think of to try to help her. She was not from a poor background or anything, but the intersections of COVID, you know, being a woman of African descent, all of that stuff coalesced and resulted and contributed greatly to her untimely death. And so work like this is critically important and really important for us to continue to do all of this kind of work on an ongoing basis. I don't think we should go for the low-hanging fruit, though. I think we need to go for some of the more difficult things like the silos, breaking some of that down. So thank you so much, Teresa.
Yes, I agree.
Thank you. And thank you for everybody who's joined. I still would like to leave this open, and I just want to say, I know how everybody feels, Nola, our deepest condolences. There's mental illness and mental health issues have impacted all of our families and all of our communities. And we feel that deeply. And I'm so sorry for what I consider probably an untimely death. I also want to say that it was we started off thinking we're going to have a breakout on Latinx, we're going to have a breakout for African Americans, we're going to have a breakout for American Indians, et cetera, and it's you, the feedback that you gave that said we would be so much more powerful to come and have a dialogue that crosses our cultures, our races, our immigration status, et cetera. And so thank you for that input, and I'm so glad we made the decision to pivot and move in that direction, because I do believe that we are stronger with all of these voices here today. We are so much stronger with forwarding any of these objectives than if it would have been one group or another. So many thanks to you who, I think, Manola, you were one of the leads in that suggestion. I want to thank you for that. And the only reason we did the immigrant and refugee as a separate group is because so many of their circumstances are unique, whether they're DACA students or, you know, some of the coming across the country. And it was not based on any race or ethnicity. We had somebody representing Afghan families. So just thank you so much.
Teresa, if I could add something, can you hear me? If I'm going to have to run and pick up my kid from school, but you know, I really want to commend all of you for doing this, and to state the obvious that you're because of the state that you're in a position to really run with this, and not just the low-hanging fruit like we were saying, but everything. I'm in a different state and a different reality. Sometimes I feel like it's a parallel universe. You know how in the Star Trek, if there's any Star Trek fans here, you got the evil Kirk and the evil Mr. Spock and that other parallel universe. Well, you know, in Texas, it's a different reality. I think we are near the bottom of the list, if not at the bottom of the list, in investments in mental health and many other things. And you know, just last spring, the board, the social work and psychology NLPC board, wanted to take away protections for LGBTQ and individuals and people with disabilities. You all remember some of that, and people across the country came out and supported us, and thankfully they walked that back. So you know, no government is perfect, and there's always battles to be had. But at least you're in a state that understands the importance of these things, and it's wonderful that you're doing this. And you know, when you've solved it over there, come over here and help us.
Come out here and join us. But you know what? Maybe the next step is to even broaden our dialogue and to help our, our colleagues across the states that are suffering. But let's start, we really want to start by taking this agenda and actualizing it and moving forward. And then, but it doesn't mean that we have to wait. We still could join you and, work together on this effort.
Yeah, we'll keep fighting.
Thank you so much. You, all of our panelists, and especially how wonderful to have our youth panelists, because this could have been intimidating, but it wasn't. They were great. They were sharp. They had a lot to tell us, right? And we need to take that to heart. Thank you. Any last comments before I make a final thank you pitch? Well, my boss and the CEO of Fred Finch, Tom Alexander, he got kind of cut off in the morning and he wanted me to say a few words. And there is no way that I'm going to be able to read his 5-page presentation. But I do want to say a few words, just take a few of his words from his talking points and be able to share them in his honor because he was unable to be here. First, I want to thank both him and Chris Donor-Mertz for really supporting us as the workforce to be able to do something like this. Oftentimes people go like, what are you doing? What? Is that really what we do here? You know what? It is what we do. We all need to do this. We all need to step up and make this a part of our work and our goals and objectives. But I first wanted to start off by really sending a thank you to our sponsors that made this a reality. John Muir Health is one of them. Kaiser Permanente, the Hispanic Latino Mental Health Technology and Transfer Center. That's a mouthful, but I think you know who the transfer centers are. They're SAMHSA contractors, and they sent Luis, so woohoo! And Proco Risk Management Services, which is an insurance company. We want to thank them because we're going to need more funds to move forward. We're going to need to take these ideas, kind of consolidate them, put them on paper, share them back with you. And let's talk about where we want to go next steps. Are you guys in? All right. So he also wanted to say that as an agency, we're committed to facilitating deep and honest conversation and dialogue to pave the way for innovative approaches and actions that address racial and cultural gaps within our systems of care. And he goes on, and I think you know where we're going. It's all about improving our services, bringing people into the field because they don't see that we're burnt out. We love our work. We're here to help. We're here to be a voice of reason and leadership, and mostly to generate really positive experiences for those that we serve. So I'm going to end it with that. And you all know the next steps. I'm going to put together a paper. Give me 30 days, because I'm going to need a couple days off after this. And let's create a network. I'm hoping to create a network so that we're in constant communication. We'll maybe create something in an email format or another format that's more intuitive, as my friends say, a little bit easier. We tried this was recommended to us. It was a little tough, and I am so sorry for the full pause, and my deepest apology to our morning individual that was supposed to do a blessing in honor of our Native American communities. So with that, sending you all love, sending you off, and you're not leaving. We're not letting you go. We're going to continue down this path. We're going to make a difference. Many blessings, or as Luis and the Puerto Ricans say, bendiciones.
Bendiciones.
All right.
Gracias, everybody. Thank you.
Thank you, everybody. Much love.